Hello, my name is Ben Bursick, and this is Palliative Care for Older Adults in Various Settings. By the end of this session, the learner will be able to discuss the differences and similarities between palliative and hospice care, identify and describe three key components of palliative care, describe when palliative care is introduced to a patient's care plan, and identify three elements of palliative care and how they may be incorporated in the learner's future role. Palliative care, simply put, is addressing the wishes and needs of the patient. It can perhaps be described as quality of life care rather than curative medicine. This does not mean that a decision is made to stop all curative medicine and the focus shifts to that of comfort. And this is not only regarding medicine, for example, pills and capsules. Let's say a fellow has been on a low-salt diet for decades. It may be that what is most important to him is to eat whatever he wants, including salt. The goal is relief or comfort and less effort on the mechanisms of modern medical treatment. This care does not necessarily contribute, encourage, or accelerate death. Rather, we aim to enhance a person's quality of life, however long that may be. Therapy is not discontinued across the board. Therapy that may serve to prolong lives, such as radiation or chemotherapy for a person dying of cancer, may be continued. Additionally, medications can be examined to determine which should be stopped and those which should or could be continued because they provide symptom relief. We need to understand the patient's wishes and make them our wishes. What is clear is that empathy and compassion are cornerstones of this type of care. According to patients, compassion involved responders using themselves as an instrument in the relief of suffering. We should strive for compassion. Palliative care and hospice are unique entities, but both have similar characteristics, and certainly there is overlap. The Hospice Foundation of America describes hospice as care that addresses physical, psychosocial, and spiritual distress focused on both the dying person and their entire family, and that this care addresses symptom management, coordination of care, communication, decision-making, clarification of goals of care, and quality of life. Hospice is specifically end-of-life care. Significantly, it has been found that on average, hospice has received 20 days and palliative care 38 days ante mortem. It is also interesting to note that regarding hospice, Medicare has unique benefits such as respite care and provides support in the form of grief and loss counseling for the family of the deceased that was on hospice for up to a year after their death. These are not necessarily part of palliative care, and payment for them may become an issue. Palliative care encompasses a lot of area and is much less defined than hospice. The best way to understand it is to frame the situation that while the person with the diagnosis or the condition may not get better, we can improve their treatment by identifying and then focusing on what is most important to them. The palliation may progress until the clinical picture is likely to be the end-of-life care, either hospice or comfort measures only, but again, this is only a portion of the whole. Palliation can start much earlier and be included as part of the comprehensive care for any complex disease state, as you will hear on the next slide. An elderly gentleman, somewhere north of 70, was admitted to the hospital after a clinic visit. He had a long cardiac history. The clinic visit and the admission were due to increasing disability and deconditioning. The palliative service had been part of his care for many years, initiated by the cardiologists. He was clear with his goals, and having advanced planning in writing was also very beneficial. It quickly became clear he was looking at a long hospitalization. He chose to transition to comfort care, and his wife supported his decision as it was well established that this was his plan for when he became burdensome. He was likely to be days in the process of passing, and likely could have made it out of the hospital somewhat easily. His wife was capable, but the patient had no interest in dying at home. He felt the expert hospital staff was most prepared to care for him, and preferred that his wife be allowed to sit with him, without feeling that she was responsible for taking care of him. He was off oxygen and pretty much everything else, except for morphine for dyspnea and discomfort. As he declined over the first few days, it became clear that the morphine was not being well tolerated, so it was switched to Dilaudid with good effect. He stayed in the hospital 5 days before passing, very comfortably, according to his wishes. Clearly, palliative care was instituted early by this man's care team. Kudos to them. This illustrates, too, how having a documented advance directive facilitates planning near the end of one's life and alleviates pressure at a stressful time. As previously noted, palliative care can begin at many places along a person's healthcare journey. The talk specifically refers to when it is clear that improvement from a condition or a disease state is not expected. The talk can be directed at the patient, or in the case of trauma or of rapid decline, can be directed at family that are present or communicating by alternate means. The talk can also be instituted much earlier. This can be at the time of diagnosis of complicated disease states, recognition of multiple comorbidities, and of course terminal illness. The early intervention should include discussion of an advanced medical directive. This can be in the form of a physician's order for life-sustaining treatment or POLST, a living will, and other legally binding documents. The talk should be in an environment conducive to communication. Cell phones, pagers, etc. should be switched off. Having this discussion involves being present, absolutely, and invested in this conversation. Utilize teach-back tools such as ask, tell, ask to maintain communication. Invite the patient to speak. Help them be part of the communication, even if this involves silence. Be an active listener. For the talk, create a situation that supports and validates a person's feelings. As always, when discussing health, there are likely to be barriers to people accessing palliative care when needed. Some of these barriers may be cultural or even political and must also be considered. Ultimately, we need to address the situation. We need to identify what is important to the patient. We need to identify their goals. For goals of care, we need to consider what is important to our patient, what is important to their family. Do we have the ability to make these goals happen? Is it important to make these goals happen, or at least do our best attempting to do so? And who should be on the multidisciplinary team to make these goals happen? The answer to the first two questions is we have to ask. These are unique to each person. The answer to the second two questions is yes, and the answer to the last question is whomever is needed to make the best outcomes for our patient. Recognize that this discussion is on a timeline, that this discussion will be ongoing. Goals may change over time. Quality of life will evolve into quality of death. We only get one opportunity to die. Be part of helping someone to do it right. Very rarely is the decision to switch to palliative care only that of the older adult. In many cases, the person changing their care may not be able to decide on their own. Frequently, grown children, possibly of advanced age themselves, may be making or assisting in the decision to transition to this type of care. The most important consideration, then, is to include the family in discussions, but stress that ultimately we are discussing what is best for the person receiving the care, not necessarily for the family, and most certainly not to project their own mortality. Cultural consideration must also be allowed. Many family dynamics are different than your own, and these values must be accommodated. Family members may also misunderstand the symptoms patients are experiencing and may try to intercede. Additionally, it is well established that family members often underestimate the patient's pain intensity. For instance, just because a patient has not traditionally used pain medication, or even any medication, does not mean that they will not need or benefit from pharmacologic intervention at some point. The patient is the focus. Yet again, addressing advanced directive type discussions, living wills, etc. are best done early when confronting diagnosis and are suitable at any age. Another elderly gentleman in the hospital had been stuporous since admission. He lived in a remote rural area and had been discovered unresponsive by a neighbor checking in. The rural hospital had transferred him to the larger hospital that they felt was more prepared to provide his care. There was no known next of kin, but through diligence and hard work, a social worker was able to find an estranged daughter. She and the patient were of limited means, but she was certain that the patient felt strongly about not dying in a hospital. The clinical picture was that this gentleman had hours to days left, but was not likely to tolerate the long trip overland. Again, through much hard work, the social worker and the case managers were able to get the AirMed service that had flown him here to donate the flight home. The patient survived the journey and was able to die in his own bed, with his friends and his daughter nearby. The extra effort to honor a patient and their wishes is not really extra. It is our duty as caregivers. The case manager, the social worker, and the air transport service in this case demonstrate compassion in their approach. While this story is probably a demonstration of hospice, it certainly can apply to aspects of palliative care too. In 2007, the National Quality Forum released guidelines of practices for palliative care. These guidelines, now maintained by the National Consensus Project, continually evolve. Currently in their 4th edition, they define 8 domains of care. The first domain addresses the interdisciplinary component of the care team. The 8th domain addresses the ethical and legal aspects of care. The intervening domains address symptom management. These symptoms encompass the physical, psychological, social, cultural, and spiritual or religious needs of the patient. Symptoms will vary according to the nature of what has brought the patient to this situation, this aspect of care. There may be pain, there may be emotional or spiritual distress. Management of these symptoms may include medication or lack thereof, patient, perhaps home health care to facilitate independent living even as physical condition declines. Addressing the symptoms will again depend on the interdisciplinary team required by palliative care. Therapists, chaplains, pharmacists, physicians, nurses will all need to be included. Medication is part of any discussion regarding patient care, even palliative care. In a hospital setting, there is generally IV access available for intravenous medication administration. Outpatient, in a person's home, or even in a long-term or assisted setting, medications are most generally given orally. It is important to note that many of these medications have contraindications or are listed in the AGS Beers criteria as being potentially inappropriate for patients over 65 years old. Again, the rules for palliative care are driven more by effect rather than long-term or even short-term risk. It is generally best to refer back to the personal goals that the care team is striving for. Palliative care can happen anywhere. The most important considerations are that the person receiving the care is safe and that the care is appropriate. Just be sure to make accommodations for this person's wishes to be honored, whether this is in a hospital, a care center, or at a home. And the takeaways then are palliative care and hospice care are related. There are also distinct differences. Palliative care should start early, especially if discussing a terminal or debilitating chronic illness. And this care should be patient-driven, goal-oriented, and should involve a multidimensional, interdisciplinary team. Thank you.